Hello, my name is Cheney, and I'm a PGY4 at the University of Utah. I'm honored to accept the Richard S. Materson ERF New Investigator Grant for my project, Neuroma Cooled Radiofrequency Ablation for Refractory Phantom and Residual Limb Pain, a pilot study. This is a project I've had in mind since PGY 2 year. I'm the son, grandson, grandnephew, and nephew of prosthetists and orthotists. I knew I wanted to help amputees, but I also knew I wanted to do it differently than my family. This grant will help me continue to do the research that will benefit the amputee, rehabilitation, and pain population. Our clinical team was comprised of myself, Dr. Zachary McCormick, Dr. Colby Hansen, Dr. Richard Kendall, Dr. Chris Duncan, Shelley Cunningham, Bo Sperry, Dr. Aaron Conger, and Dr. Taylor Burnham. Our team was based out of the University of Utah. The study was based on a case study we had previously published, which had looked at cooled radiofrequency ablation for residual limb and phantom limb pain in a single patient. This patient had recalcitrant phantom and residual limb pain. An MRI identified a neuroma in the infrapiriformis distribution. Using ultrasound guidance to identify the neuroma and fluoroscopy to avoid important anatomic landmarks associated with other peripheral nerves, we were able to use cooled radiofrequency ablation to ablate the distal stalk of the neuroma. At 8 weeks post-ablation, the patient reported nearly 100% improvement in phantom limb pain symptoms. And at 6 months, the patient reported 95% reduction in phantom limb symptoms. Such profound and durable pain relief from this procedure inspired us to expand our protocol. While radiofrequency ablation is not a completely novel technique for phantom and residual limb pain, no one has ever evaluated cooled radiofrequency ablation in this patient population. Cooled radiofrequency ablation uses a thermal probe but with an adjacent water system that helps control the surrounding tissue heat during thermal ablation. This picture depicts both probe and the tubing system required to pump the cooled water. Due to the often traumatic or surgical severance of residual limb nerves, the nerve course can often be irregular. Standard radiofrequency ablation requires a very specific angle of approach to achieve thermal ablation, which can be challenging in our amputee population. Cooled radiofrequency ablation, on the other hand, projects a spherical lesion, making the thermal nerve ablation much more achievable. Whether this confers more significant or more durable pain relief for our patients is the intention of our study. In addition to evaluating pain outcomes, we will also be tracking adverse events related to the procedure, patient pain medication use, prosthesis use, and ability to perform activities of daily living. On behalf of my University of Utah family and the patients we serve, I'm honored to accept this award.